Good afternoon, all the faculties and delegates, and warmly welcome to our AEG workshop. And I'm Noemi from Manly General Hospital. And also warmly welcome again to our Myanmar AEG Interventional EUS webinar focusing on the pancreatic cystic neoplasm. And as you all know, we have two expert faculties here, and Professor Pradanchai Kongkran from Chulalongkorn Hospital, Thailand, and Dr. Raymond Tan from Hong Kong. This is the first webinar for Myanmar during this COVID time. And it is actually we moving the previous date, and so I would like to apologize all the faculties and the participants for any inconvenient cause for moving to the current date. So I really thanks to the Professor Lawrence Ho, Flora and AET team for arranging this webinar very smooth. And we have the very good number of registrations for this webinar, nearly 137 participants, and I'm very pleased for that. They are from all the various countries, and including the regional, not only from the Nepal, Cambodia, and all Thailand, and everywhere from the region up to the Western country, UK, Mexico, and Peru. So I'm very pleased for that, and I hope we will have a very fruitful and very knowledgeable the webinar. And so I'm really thanks to all the faculties and the participants. And also thanks to the joining us, and I now handed over our section to the Professor Tanta A from Tingkantun Sambian General Hospital, and which team, and they hosted this webinar. So Prof. Tanta A, please. And Prof. Tanta A.
Hello.
Hello. Hello.
Hello.
Hello. Hello.
Hi.
Oh, so the Tingkantun Sambian team have the network problem, and so we will have a pre-test and post-test session. So Jason, shall we start the pre-test first before reading from?
Sure, this is Jason, so I will take care of the pre-test session. And okay, so I'm now launching the pre-test. So there will be 5 questions for the pre-test, and the section will last for 5 minutes. So everyone can take your time to answer the question accordingly. And the question will be asked again in the post-test session, and the answer will be explained by our faculties after you complete the post-test. So now we're gonna start the pre-test now. So I think everyone will see the screen. We'll have a pop-up screen with the questions, so please take your time. So I see there are some newcomers. So we are now undergoing the pre-test section. So the pre-test will last for 5 minutes. So 2 minutes has passed, so we have 3 minutes left. So you will see a pop-up screen which have 5 questions altogether. Please take your time to answer the questions by clicking the answer accordingly. And the questions will be asked again during the pro-test session after the lecture given by our faculties. And the answer will be explained by our faculty as well after we complete the post-test section. So all attendees are welcome to answer the questions. Please take your time. Okay, so the pretest is end. So we can move on to the next section. So our next section will be our first lecture, Role of EUS in Diagnosis of Pancreatic Cystic Neoplasm by Professor Conkham. Thanks very much for participating in the pretest.
Are you ready?
Yes. Yes. So please turn on my video.
Yeah. So as there is some problem with the network problem with the Tinkanchun General Hospital, so we will skip the session. Greeting from the Tinkan. So she is ready now. So Professor Tantai. Professor Tantai. Yes. Yes, this is now. So I handed the session to the Prof. Tantai, head of the department of the Tinkanchun General Hospital, and the Tinkanchun team is.
Sorry. I'm sorry. Good afternoon, everybody, distinguished guests, from Professor Brandon Chai, Professor Dr. Raymond Tan, and Flora and Olympus team, both Singapore team and the Myanmar local team, and Professor Nguyen, AEG representative, and Professor Momie Ao, and all the attending doctors. Greeting from Tinkanchun General Hospital, Yangon, Myanmar. I'm really grateful to have thanks all of you to organize this kind of educational program organized by AEG, despite everybody is busy in COVID time. Actually, we have RFA equipment in our hospital since last year. We are waiting someone who experts to teach us to start this machine, but in the workshop, unfortunately, because of COVID, all the workshops program were cancelled. But again, fortunate to have this webinar program by Professor Brandon Time and Dr. Raymond Dunn, and to teach us for pancreatic cystic neoplasm lecture, as well as how to use RFA machine technique, basic techniques to tip and tricks of the technique to us. And then we hopefully expect that we'll have a hands-on workshop sessions in the near future in a hospital. So that thank you once again. So all the audience are waiting and excited to watch your fruitful webinar. Thank you, all of you.
Thank you,
Professor Nguyen, please.
Yeah, Professor Ndai. And so we will start the session. And the first speaker is Professor Pradan Chan Konkran, and from the King Chulalongkorn Memorial Hospital, Bangkok. And he is a well-known endoscopist and a leading gastroenterologist. And also the EUS is from the Bangkok, and is well known from all over the world. So Professor Pradan Chan, please.
Yeah, so hello, can you hear me? Hi. My internet is not that good, so then I cannot use the video. Anyway, I sent my video presentation to you, so please open the video. And thank you very much for your invitation. And I'm happy to join, and I will listen from my side here. Yes, please go ahead, please.
Thank you very much, Prof.
Okay. So hello everyone. So today I would like to thank the organizers, Professor Lee, Professor Ang, and Professor I, for inviting me to give a lecture in the Myanmar workshop. And today my topic is EUS-guided cyst ablation and RFA techniques. So now I know this lecture is supposed to follow Pradam Chai's lecture, but I'll try to keep this simple and practical so you won't get lost, okay? So let's see, okay, I'm gonna start here. So now just a quick overview. So in our practice, I think it's useful to divide the pancreatic cystic lesions into neoplastic cysts and non-neoplastic cysts. So pseudocyst is a good example of non-neoplastic cysts. But for neoplasms, cystic neoplasms, it will include serous cysteinoma, mucinous cystic neoplasms, IPMNs, and also solid pseudopapillary tumor, and sometimes cystic degeneration of PNET, and also cystic degeneration of adenocarcinoma. So I think these are probably the key questions that are important in our clinical management. What is the nature of the cystic lesion? Is this a neoplastic cyst? Is this a mucinous cyst? Is there a malignant component? Or is there a risk of malignant transformation if no overt malignancy is detected? And what should we do about them? So are they good surgical candidates with a cyst that has indication for surgery, or they have indication for resection, but they're not good surgical candidates, or they are, basically asymptomatic cysts with low malignant potential that are best served to have conservative management? So now here, I think we should focus on mucinous pancreatic cysts for the purpose of this lecture. So for the two main differential diagnoses of mucinous cysts, we're talking about MCN, mucinous cystic neoplasm, and also IPMNs. So Now, for mucinous cystic neoplasm, you usually see this in females, and the location of the lesion is usually near the tail of the pancreas. Now, sometimes it's a unilocular lesion, maybe a thickened wall, but sometimes we also see quite a lot of septations. Fluid will be mucinous, and if you analyze the fluid, you may find a high CEA. But in patients with IPMN, so I think the key is to observe if there is any obvious communication with the side branch of the pancreatic ductal system. So, but of course, branch duct IPMN sometimes may be difficult to differentiate from mucinous cystic neoplasms if they are very small. So, but for main duct IPMNs, I think things are more clear-cut because the main PD will be dilated. But I think why we need to try to make a differentiation between these two types of mucinous cysts, because when you do EUS-guided cyst ablation, some experts will be concerned about overt communication of the lesion with the main PD may be associated with high risk of complications such as pancreatitis. So now, just to remind everyone, so now the for KUKA, the Sendai guidelines have been updated in the 2017. Now, I know there are other guidelines from AGA and also from the ESG and from Europe. But I think for practical reasons, I want to use this guideline to explain some of the features of, for example, the high-risk stigmata that may be suggestive of malignancy, and also the worrisome features that may give you some indication that you should consider treatment of the cyst. So now, if patients present with overt symptoms such as obstructive jaundice and a big mule nodule or a very dilated PD, you have to be really think about if this patient already has a malignant cystic lesion. But if everything else is kind of in between, you start to see some worrisome features here, then EUS is definitely helpful. And I think whether you want to do surgery or cyst ablation, I think this is also depend on local expertise and the overall fitness of the patient. So I think now a lot of the indications of who should get EUS-guided cyst ablation, of course, right now are probably based on a case series and also maybe some RCTs on the treatment modality, treatment agents. But then many of these are from expert opinion also. But I think we can try to come up with some I guess, goals here. What are we doing with the EUS-guided cyst ablation? So I think here we want to focus on destroying the neoplastic lining of the cystic tumor, and is to eliminate the lesion or to reduce its likelihood for progression into cancer. But also, the best cyst candidates should be unilocular or oligolocular cystic lesions greater than 2 centimeters, and this should be presumed or confirmed mucinous cyst, and without overt signs of malignancy or without overt communication with the main PD, and also in patients who refuse surgery or high-risk surgical candidates. So, and when we do therapeutic procedures, I think getting to know the absolute and the relative contraindications will be very helpful. Now, I think for the absolute contraindications, these are quite intuitive. So, but I think the key here is in someone who already has pancreatitis or even necrosis, I think these probably won't be good candidates for cyst ablation. And also someone with cancer or short life expectancy, that should be a contraindication also. But for relative contraindications, I think these relate to the technical success of the procedure. For example, if you have a cyst that has many septations or thick walls, you know that sometimes the ablative agents may not get into the cells very well. So I think these would be consideration. Also, open communication with the main PD and also prior history of pancreatitis. I think these are also features to watch out for. But whether you want to ablate something with mural nodules, I think this is a subject of debate. If you have a really tiny nodule, maybe still okay. But obviously, if you have a big solid component, I think you should really consider this as a case of a cancer. So now, this is an example to show you that don't just get fixated on the cystic component. Now, you may get carried away by saying, okay, I see a big unilocular cyst looking good here. But look at this pancreas. This pancreas has a difference in enhancement pattern on this contrast CT. The body of the pancreas is totally abnormal. This probably is a cancer because when you look at the celiac artery, this is encased by what looks like an infiltrative mass here. So this is not just an MCN, this is a mucinous cystadenocarcinoma. So don't ablate this cyst. So here, this is cancer. So now on EUS, now because the cyst is quite obvious, sometimes you get very excited by finding a big cyst looking like a MCN, but watch out for solid component like this one. Now, this solid component pointed out by the red arrow, this is not a regular parenchyma. This is a cancer. Look at, this is very hypoechoic. So watch out for things like this. So I really think appropriate workup of the cyst before proceeding to ablation would be very helpful. And I think the actual practice will vary based on each institution. But I think you should make sure that the cyst is not just some very benign asymptomatic cyst with low malignant potential. If possible, I think we should have cross-sectional imaging, EUS, plus or minus a fluid analysis before we proceed to this type of therapy. And also, if there's a concern, maybe you should consider like having a research protocol, just making sure people are on the same page when they try to select patients for this type of procedures. So and other considerations. So now, just like performing EUS-FNA for a cystic lesion, so should think about prophylactic antibiotics. Now, I know that there's some new studies saying that maybe prophylactic antibiotics may not fully reduce the risk of infection, but I think from a traditional sense, I think especially if you're doing a therapeutic procedure, I think you probably don't want to add the risk of infection in this type of cases. So I think prophylactic antibiotic is still good, and this should be before the procedure and continue for 3 to 5 days after the procedure. And in terms of needle choices, we're talking about mucinous cyst here. So we are anticipating viscous mucinous fluid. So if possible, 19 gauge needle is preferred. But if there's a difficult position, 22 gauge needle may be okay. But give it a try with the 19 gauge if possible. And if the cyst fluid is very viscous, consider some suction pressure, and then also use the technique of injecting some normal saline into the cyst to dilute some of this mucin before you aspirate things out. So I guess also based on some expert opinion, it's also suggested don't completely collapse or empty out the cyst. Maybe you should leave a little rim of fluid around the tip of the needle so you can actually see things clearly when you inject the ablative agents. So for agents that have been evaluated in studies that include ethanol lavage only, ethanol lavage followed by the infusion of paclitaxel, or alcohol-free saline lavage followed by a mixture of paclitaxel and gemcitabine or laromacro. So now this is, I think this is a good paper by Dr. O, published in GIE, and then it has some good schematic diagram and video to show you how this is done. So now it involves a few steps if you really want to do cyst ablation with alcohol lavage plus a chemotherapeutic agent. So now you have to put the needle in. Usually you puncture through the septate, and then you get into the area. Then you start to aspirate the content out, and then you infuse the alcohol back in, allow some time for a little retention, and then followed by aspiration of the alcohol. And then you can inject paclitaxel into the cyst. But I think you should be aware that paclitaxel could be also a very viscous agent. So watch out when you inject this, okay? So, and you should start to see some re-expansion of the cyst to the original diameter. So now here is a video from GIE. Now here is a cyst with a few septations, looking pretty okay. No big solid component. So let's see. So I think it looks pretty big, at least 3 to 4 centimeters. So now here's a needle, and then the operator has already started aspirating the fluid. Now you can see the cyst is collapsing. Now see the needle tip there, and then it will take some time. And then now the cyst fluid looks pretty clear. Here, FNA is being infused, and the bubble is actually a good sign that you know this is getting into the cyst. Just like when you do a CPN, you see some snowstorm appearance when you inject alcohol. Now, so when you get the fluid back out, you will have that kind of appearance there. So now you're infusing paclitaxel in there. Okay. So I think besides focusing on clinical outcomes, I think we should also look at what are the potential adverse events. So now, actually the concept of cyst ablation by EUS has go way back. As early as 2005, people have been talking about the use of alcohol lavage. And at that time, well, it's technically feasible and reasonably safe, but you can see that the rate of complete resolution is not that high. It's about 30% or so. And then over time, now there are people from United States, other countries, and Korea trying to see what's the best approach to this. But when you start doing more studies with alcohol and including different types of cysts, then now you start to see some adverse events. For example, abdominal pain or even pancreatitis. But sometimes you may get things like vascular thrombosis, so you have to watch out for these. Now, since 2008, so there's report on the use of alcohol lavage plus paclitaxel chemotherapeutic agent, and in these patients, who receive combined treatment, the rate of complete response has increased to over 50%. But again, we're still seeing some adverse events. So people start to think about, is this related to alcohol or is this related to the technique itself? So, and most recently, in 2017, then there is a RCT comparing alcohol-free regime with the traditional alcohol plus chemotherapeutic agents. And we can see that if you don't use alcohol and just use a saline plus chemotherapeutic agent, you still can achieve a very high complete response rate. And the only time people observe adverse events was actually in the group with alcohol lavage. So this is quite good data to suggest that maybe the way to go is do it without alcohol, and it's just with saline plus chemotherapeutic agent. Okay, now this is a landmark paper from a Korean group, and you can see that now they include quite a number of different lesions. They include MCN, serous adenoma, and some the so-called indeterminate cysts. Now, I think it's a little controversial, by ablating the cyst without obvious diagnosis, but sometimes a clear-cut diagnosis may not be possible. So here, if you look at the histological examination, you can see that the mucosa, the linings of the cystic lesion has been ablated. So, and also if you use CT scan for follow-up, you can see a decrease in size of the lesion. Okay, so now this is the paper I was talking about, using an alcohol-free regimen with chemotherapeutic agents. So now I think here this is a very good study to show you that alcohol may not be needed for effective cyst ablation. And but again, there is some limitation because only one ablation session is used, and the study is not to power the sample size, not powered to show results of high level of statistical certainty. So I think we should keep an eye on the development of alcohol-free regimen. So what do we do after cyst ablation? I think we still need to follow these people up. So a good way to go is cross-section imaging, at least half a year for the first year, and then maybe annually. But I think we should do this according to the patient's age and medical conditions. And also this is to for the monitoring of recurrence, and also for incomplete ablation. So now, since we're going to talk about RFA today also, I'm going to trying to transition this over. Now, so interestingly, besides the so-called injection therapy with chemotherapeutic agent, now people have studied whether RFA is useful in terms of cyst ablation. Now, so in 2015, Pai's group used this through the needle probe. This is a Habib probe, 1 French in size. And treated 6 patients with PCN, and 2 of them show complete resolution during the follow-up period. Now, I think here the challenge is the very small size of this through the needle probe. I'll tell you, in real life, you just have to be very careful with this very teeny tiny probe, because sometimes you could easily damage it because it's just 1 French in size. And also, when you put this probe out, you have to do it kind of like you keep the probe out, but then you basically have to retract the needle back to expose it instead of just sticking the probe out. So, and also you have to make the probe in contact with the cyst wall, but sometimes it could be challenging with such a small device. So so with this, I'm going to transition and then go into the topic of EUS-guided RFA. So now, since this is a short lecture, I'm just going to focus on the basics. Now, first of all, RFA can be applied to a different types of lesions. But just to go over some concepts, here we talk about this is a direct ablative technique, and then we're using high frequency alternating current that generates heat, and the aim is to produce coagulative necrosis in the target tissue. And I think as of now, we have seen 4 types of RFA probes being reported for the pancreas. So some are needle-based type of platforms. So, and then 3 of them are actually needle-based. And the size of these needles are quite big. Now, I think the smallest one will be a 19-gauge needle, but then there are also platforms that will be as thick as a 14-gauge. So pretty interesting and a pretty big catheter needle to use. But also you have the through the needle platform, the one French Habib probe. So now these are the technical information and also the way they look. So I think in Myanmar, they have the Taewong, the StarMed probe here. So I think it's a pretty easy to use platform. I think the 19-gauge needle, I think, is a very good device. So I think the key is to know how to use the cooling system and to follow some of the the company advice on the settings and then things like that, so you don't damage the echo endoscope, things like that. So, and also interesting thing is now some of these devices are monopolar, and a large one, the 14-gauge device, is a bipolar one. So it's quite interesting. So, and some have an internal cooling system, such as the StarMed system. So now this is a video that is from Sandeep's group. So oops, it's not playing. Let me see if I can play this. Okay, so now here this is NET being ablated by the RFA probe. So the probe is in the lesion. Now here, as you can see, now the whitish area is the coagulative effect produced by the heat energy. So you can actually see a rough estimate where the energy is going here. So now I would point your attention to this recent publication in the EIO. It basically summarized, the studies we have so far on the use of EUS-guided RFA on pancreatic tumors and some periluminal lesions. Now, here I want you to see that now, initially, these case series were quite small, but over time, we're getting at least series, maybe up to 20 patients. So the things that they were ablating include neuroendocrine tumors, or even locally advanced pancreatic cancer or metastatic lesions to the pancreas. So now here I would ask you to try to remember the two things about this procedure. One is a technical success and one is a clinical success. Now, I think here you can get an idea that there's actually a very high technical success rate, but for clinical success, I think later on you see we have to define what exactly is a clinical success for different targets, okay? So now here is more data just to tell you about the type of adverse events that you may see here. For example, risk of bleeding, pancreatitis, or even perforation or infection. So I think abdominal pain could be a pretty common finding, but I think obviously we don't want to see some serious adverse events such as perforation, bleeding, infection, or pancreatitis. But I think you should be aware of these potential complications. So now, obviously, I think if the lesion is very close to pancreatic duct, the main duct, I think you just have to be very careful, because sometimes you can damage the duct, you can cause pancreatitis, and cases of ductal stricture has been reported. So if you're very close to a vessel, you have to be careful not to cause any over treatment leading to thrombosis. Also, now here, this is another nice study. I think it's interesting in the sense that it described application of RFA in neuroendocrine tumors and also pancreatic cystic neoplasms. So as you can see here, so they treat NET and also IPMNs and MCNs. So they mainly treat the lesion at the body and the head region. So now, interestingly, they report quite a good response in neuroendocrine tumor. And in 12 months follow-up, you can get a response up to over 80%. Of course, there will still be some lesions that cannot be completely treated. And for PCNs, looks like the response rate is also quite good, more than 60 or 70%. Now, if you look at this type of numbers, this may be similar to what you can get from EUS-guided cyst ablation with a chemotherapeutic agent. But I think here you just have to think about what is the relative incidence of adverse events now, because pancreatitis, perforation, or the main duct stenosis can happen. So I think we need more data to see which technique is better. So I think just a note on how to define clinical success. Now, I think for NET, I think it's very easy to say, well, if it's a functional NET, if patient has resolution of symptoms, you define a clinical success. And if they have loss of contrast enhancement on contrast EUS of the lesion after RFA, you can probably still call this clinical success, even if the lesion is not functional. But then for patients with metastatic cancer with the aim of local control, now the patient is still having metastatic cancer. So I think how to define clinical success maybe is related to, for example, the size reduction on imaging, or maybe even sometimes it's pain from the tumor. So if these are the endpoints, I think, yes, I think there will be some improvement in terms of quality of life. But it is possible that the overall disease course may or may not be very different. But of course, we need more data on this. So I want to point you to, besides knowing the technique and then the indications, I think you should be aware of some potential complications such as pancreatitis, things like that, or fluid collection that can happen after this type of therapy. Dear organizers, ladies and gentlemen, in summary, EUS-guided cyst ablation is a treatment option in selected patients with unilocular or oligolocular cystic lesions greater than 2 centimeters, presumed to be mucinous cysts. Of course, you don't want to treat things with a cancer, and then you probably you don't use in people with few surgery or at high risk of surgery, and usually you can get a high response rate with chemotherapeutic agents. Alcohol lavage may not be necessary, and it's often associated with adverse events. And EUS-guided RFA is a promising local control technique for the pancreatic tumors, but further studies are needed to better define its utility in patients with metastatic cancer. Thank you very much.
Thank you very much for the Dr. Raymond Tan, and for a very clear and a very informative lecture. So we will do the question and answer session at the end of the two speakers. So Dr. Pratanchai, Flora, is this ready for the Professor Pratanchai lecture?
Yes, we will play on our side. So
this is Jason. I will play the slide now.
Hello everyone, my name is Dr. Pratanchai Kongkham. I am the current president of the Thai Association for GI Endoscopy, and I'm also the director of the Chulalongkorn GI Endoscopy Excellence Center. Today I'd like to thank AEG organizer from Thien Kan Kun General Hospital, and also course director Professor Newni, Sir Tan Tan Ai, and also Dr. Professor Ang for inviting me to give a talk today. My talk today is the role of endoscopic ultrasound in diagnosis of pancreatic cystic neoplasm. So I'll cover the classification of pancreatic cyst,
diagnostic test, guideline, natural history, clinical problem and solution, and also innovative management of pancreatic cyst. So the facts of cystic pancreatic lesion is that actually pancreatic cyst is common with an incidence of 3 to 15%, and vast majority of these lesions are asymptomatic with various classifications. Sometimes some of us are confused because of those classifications. So this diagram is a little bit confusing. If you look at all varieties of cysts, starting from no lining or false wall, a pseudocyst, and if cells lining epithelium around mucinous epithelium, it could be either mucinous cystic neoplasm or IPMN. And if it's clear cells and lining with benign without malignant potentials, it's a serous cystadenoma, or it can be seen in VHL-associated pancreatic cyst. If the wall lined with squamous like cyst is lymphoepithelial cyst, and cyst lined by acinar cell is acinar cell carcinoma. And some solid tumors, sometimes they have degenerative change in solid tumors, so they will present as solid cystic lesion. They consist of cystic lymphangioma, lymphoma, sarcoma, cystic teratoma, pancreaticoblastoma, cystic neuroendocrine tumor, solid pseudoperitoneal tumor, and cystic degeneration of pancreatic ductal adenocarcinoma. This slide shows radiological features of different cysts. The first one is pseudocyst. Pseudocyst multifocal is rare. Most of the time it's unifocal. Appearance of pseudocyst could be either unilocular or multilocular, and most of the time thick wall. Communication with main pancreatic duct is pretty common, and main pancreatic duct could be either normal or irregularly dilated with thrombus stricture, particularly in patients with chronic pancreatitis. For serous cystadenoma, typical feature is microcystic or honeycomb appearance. However, it can also be macrocystic or mixed. For microcystic or honeycomb appearance, it's better demonstrated by either MRI or endoscopic ultrasound. 30 to 40% of serous cystoma has central or sunburst appearance. For main pancreatic duct, it's supposed to be normal, but sometimes it's been deviated from completion of the serous cystadenoma, particularly the large one. For branch duct IPMN, mostly it has multifocal. It can be either unilocular, multicystic, or sometimes comes as a cluster of grapes, or its feature could be tubular or mixed as well. Main pancreatic duct communication is yes, although sometimes it cannot be demonstrated. And main pancreatic duct, if it's just only branch duct IPMN, by definition it should be normal, but sometimes it can be dilated as well. For mucinous cystadenoma, if some calcification will be seen, it will be like an eggshell appearance on curvilinear or on limb of the cyst. It's unicular and has septation sometimes. Main pancreatic duct communication is rare, and for main pancreatic duct, most of the time it's normal, or sometimes being compresses and then it's being deviated. This slide shows typical feature of branch duct IPMN. As you see here, there's small cyst with communication with the main pancreatic duct, and pancreatic duct has normal features. For main duct IPMN is in the opposite, markedly dilatation of the main pancreatic duct, and demonstrated by both CT scan and MRI and MRCP. So diagnostic modalities of pancreatic cystic lesion. Diagnostic means to differentiate types of the cyst. It's very difficult with the ultrasound. It sometimes is possible with CT and MRCP. And for ERCP, actually for diagnostic purpose, is too invasive. Although it's very good for demonstration of communication, but most of the time we don't need ERCP for that purpose. Endoscopic ultrasound certainly is good because it's non-invasive and it can demonstrate both parenchyma and duct. And morphological criteria of EUS, mucinous cyst may present as macrocystic septation or adjacent mass. Non-mucinous cystic lesion is sometimes unilocular, honeycomb appearance, or thickened wall if it's pseudocyst. However, with the EUS morphology alone, both sensitivity and specificity is just around 50%, and inter-observer agreement is just only fair. EUS-FNA is needed in some equivocal case, and what we are looking for, we are looking at viscosity, cytology, chemistry, tumor markers, and molecular arrangements. However, it's difficult in cysts smaller than 1.5 cm in diameter. For viscosity or string size, very simple. You just use your thumb and your index, then you can see the viscosity of fluid from the cyst. So benign lesions, certainly the length of the viscosity is 0 or almost 0. But for potentially malignant or malignant cysts, by average, length of the string size is about 3.5 mm. But sometimes with a small or pre-malignant cystic lesion, sometimes viscosity might be not accurate in some situation. So this is for sample of one case that I like to show that with a CT scan you see a very small cyst, unilocular cyst, as it is impossible for you to tell or make a diagnosis what kind of the cyst. But once we did the endoscopic ultrasound, we can see that cystic wall is irregular. There was some septation. There was some thickening in some area of the cyst. And once we did the FNA, the cytopathology from thickened wall show cells compatible with mucinous cystic neoplasm. Subsequently, surgical pathology confirmed mucinous cystic neoplasm in this case. So another diagnostic modality is cytology, which is certainly good. And in mucinous neoplasm, it will show columnar cell will be stain positive for mucin. For serous cystadenoma, it will have cuboidal shape cells and stain positive for glycogen. Unfortunately, the sensitivity of diagnosing mucinous lesion, malignancy, and serous cystadenoma is about 50% or lower than that. So sensitivity for cytology for diagnosing types of cystic lesion of the pancreas is generally too low to be used practically. So this is again, if you use features from EUS including fluid analysis for pseudocyst, you might see non-mucinous cyst. Sometimes content in the cyst could be chocolate brown or bloody, and if you do chemical analysis, it will show high level of amylase. For serous cystadenoma, EUS morphology shows thin wall, and if you aspirate fluids, it will be watery, straw color, sometimes zero sanguinous, and fluid analysis will show very low CEA. For IPMN, content of fluid is clear but viscous, positive string size, and chemical analysis will show high CEA, and but sometimes amylase level is also elevated. For MCN, fluid will have features of clear but viscous, and it will show high CEA level. However, with those features and those cystic fluid analysis, sometimes there might be some inaccuracy. So we look at several guidelines. Before we go to the guidelines, I'd like to emphasize you that most of the guideline is designed for an evaluation of branch duct IPMN. It doesn't cover other kinds of cysts except only a few guidelines. So let's start with the Sendai guideline in 2006. The cyst types that were addressed in this guideline is IPMN and mucinous lesion, and features showing high-risk symptoms: cysts larger than 3 cm with intramural nodule, when with main pancreatic duct larger than 5 mm in diameter. And it's been revised again in 2012 and 2017. So cyst types that were addressed is again IPMN and mucinous. And after both two revisions, high-risk features were jaundice, enhancing intramural nodule larger than 5 mm, and main pancreatic duct dilation larger than 10. Worrisome features: cyst larger than or equal to 3 cm, enhancing mural nodule smaller than 5 mm, thickened and enhancing cyst wall, main pancreatic duct dilation between 5 to 9 mm, abrupt change in pancreatic duct caliber with distal pancreatic atrophy. Also presence of lymphadenopathy, elevated CA19-9, and rapid growth rate more than 5 mm within couple years. So look at the guideline published in 2013 from European. They address IPMN, MCN, celocytoma, and solid pseudo-papillary neoplasm of the pancreas, and features concerning for advanced pathological condition in branch duct IPMN. Absolute indication for surgery were symptoms: 4 cm size cyst or larger, presence of mural nodules, main pancreatic duct dilation larger or equal to 6 mm, and relative indications were rapidly increasing in diameter and also elevated serum CA19-9. So that's a conclusion from European guideline in 2013. So in AGA, actually this guideline has been criticized in many conferences. The little bit difference from other guidelines. This AGA guideline, it mentions all types of cysts, so sometimes it makes readers a little bit confused. So you have to understand that cysts mentioned in this guideline is all types of the cysts. And then one of the criticized points is a significant change during surveillance. They recommend EUS-FNA, but cyst growth was not a significant risk factor because based on information, growth rate of the cyst from several studies show significant observation that we need to do something for those kinds of cysts. And this guideline suggests no significant change in cysts with no high-risk feature over 5-year surveillance. Then surveillance imaging can be discontinued. This has been disagreed from several experts. So using this guideline, you have to be a little bit careful, and you might have to compare with other guidelines recommended from other societies and other countries. So in ACG in 2018, they focus on IPMN, MCN, celocytoma, and solid pseudo-papillary neoplasm of the pancreas, and the high-risk features: jaundice, pancreatitis, elevated CA19-9, mural nodule or solid component, main pancreatic duct dilation larger than 5 mm, and change in main duct with upstream atrophy, cyst larger than 3 cm, and increase in cyst size more than 3 mm per year, high-grade dysphagia cancer on cytology that use sampling. And to simplify all the guidelines, if you don't have enough time, this probably the most practical one that you may follow to take care of your patients, and that one is recommended by revision from Sendai and up to the revision that was made in Fukuoka in 2017. So once you see cyst, you check that any on or following high-risk stigmata of malignant cyst presence, obstructive jaundice, enhancing mural nodule larger than 5 mm, main pancreatic duct larger than 10. If yes, please consider surgery. If no, look at other worrisome features. Worrisome features clinical is pancreatitis. For image appearance, cyst larger than 3 cm, enhancing mural nodule smaller than 5, thicken or enhancing cyst wall, main duct size 5 to 9 mm, abrupt change in caliber pancreatic duct with distal pancreatic atrophy, lymphadenopathy, increased serum of CA19-9, and cyst growth rate more than 5 mm per couple years. If there were some worrisome features, so then do the endoscopic ultrasound. If any of these features present, including definite mural nodule larger than 5 mm, main duct features suspicious for involvement or cytology show suspicious or positive for malignant. If no, what is the size of the largest cyst? But if yes, or please bring the patient for surgery. If inconclusive, close surveillance. So if no, then we follow the patient similar to the patient without worrisome feature, which depends on the cyst diameter. Smaller than 1 cm, CT or MRI in 6 months, then every couple years. 1 or 2 cm, CT or MRI 6 months or for 1 year, and then couple years, then interval can be up to 2 years if no change. 2 or 3 cm or larger than 3 cm. Larger than 3 cm, close surveillance alternating MRI with EUS every 3 to 6 months, and strongly consider surgery in young and fit patients. So one of the important information that you should know when you see patients with pancreatic cyst is natural history of cystic pancreatic lesion of the pancreas. Short-term risk of malignancy in low-risk branch duct IPMN is relatively low, 1 or 2% within 3 years. Long-term risk in this branch duct IPM is 3.7% at around 77 and 84 months. And if you follow the patient up to 82 months, advanced pathological condition, including high-grade dysphagia or invasive cancer, could be developed in about 5.5% of patients after 5 years of surveillance. So this reminds us that if patient has branch duct IPMN, sometimes neglecting about long-term follow-up sometimes is very difficult and might be too risky. There was a study, 108 patients with cysts about 1.5 cm. Only 1% developed cancer. In contrast to 55 patients with cysts larger than 1.5 cm, cancer developed in 7.5% after 5 years of follow-up. So size does matter. And the risk of malignancy appears to increase after 5 years of surveillance. especially lesion measuring 1.5 cm or greater. So about high risk or worrisome feature. 5-year risk of cancer, we compare between high-risk IPMN versus worrisome feature. We found that cysts with high-risk feature has 49.7% or 50% versus only 4% in patients with only worrisome features. And 5-year disease-specific survival comparing between high-risk versus worrisome is 60% versus almost 100%. So when follow more than 5 years of cysts, 22% develop worrisome or high-risk features, and 10% of these develop cancer over 102 months. So those are information that you should know. So overall, natural history I like to address that although the incidence of branch duct IPMN has risen exponentially over the past 3 decades, but the curve for IPMN-related cancer still flat. And actually, IPMN-related cancer in general is a rare event. So don't be too panicked when you see patients with cystic pancreatic lesions. So how about the growth rate of branch duct IPMN? When you compare the growth rate between 2 to 5 versus less than 2 mm per year, this is associated with an increased risk of malignancy if the growth rate is high. And all malignant branch duct IPMN grow by at least 10 mm before diagnosis of cancer. And in low-risk branch duct IPMN, growth rate was significantly greater in those lesions that developed worrisome features compared with those who did not. So, after listening to all things briefly about cystic pancreatic lesion, we still have many problems and we still need many solution or innovation to resolve all the unanswered problem of cystic pancreatic lesions. What are the problems? Long-term study for natural history is truly needed because study of natural history of cystic pancreatic lesion in the past, we have to admit that we don't know what exact types of pancreatic cyst that we were dealing with in all guidelines. So sometimes and some point, that's why it's very difficult to answer. And if you look at all over diagnostic value of all available tests with a CT scan, and accuracy rate is about 40 to 44%, so less than 50, as well as MRI. And cyst fluid analysis, pool sensitivity was 63, and although specificity was high, but sensitivity is too low. With KRAS and GNAS mutation, which I don't cover in this lecture, it seems to be promising, but price and availability is also a problem. EUS imaging alone, accuracy is not that good and it cannot be accepted in most of the cases, except sometimes you see some typical feature, for example microcystic appearance. For cystic fluid cytology, sensitivity is too low, it's around 50 to 60%. So there are current problems for management of indeterminate cystic pancreatic lesion of the pancreas. So the future, one of the future solutions is using the EUS-guided needle-based confocal laser endomicroscopy, because with this technology we can see living cystic wall. We can see the true cystic wall while the cyst is still inside body of the patients. So this is the bright future, and later years, much better efficacy of EUS and CLE have been present in several studies. I will give you as the next lecture. So innovative management of cystic pancreatic lesion, we don't have time enough to discuss about these two topics today, but pancreatic cyst ablation increasingly accepted worldwide for management of patients who have cystic pancreatic lesion. They don't want to leave it, and they don't want to come to get all the radiological tests every year endlessly. So in some of those patients, they underwent cystic pancreatic ablation, and the result is pretty interesting. The newcomer is EUS-FNA to ablate cystic neoplasm of the pancreas. Same principle with using either alcohol or chemotherapy agent to ablate the cyst RFA same, but information using RFA to ablate cystic neoplasm of the pancreas is still too small. When we have a chance, I hope that some days I have a chance to give a lecture to cover both topics to you in the future. So my conclusion about management of cystic pancreatic lesion in my practice: for main duct IPMN, mucinous lesion, solid pseudo, probably neoplasm of the pancreas, if you can make lenses, you send them for surgery. But for serous cystadenoma and pseudocyst, management depends on symptoms. For branch duct IPMN, you need to go and evaluate that carefully and following all the guidelines. In some patients, they might request you about the cyst ablation, and if they want to do that, maybe you can send to some endoscopist who can and who like to do that. But for unresectable lesions, information is very limited. Most of the time, chemotherapy, systemic chemotherapy, which is not that good, and for unresectable, so surgery is not possible. But to my practice, I done a few cases. IFA will probably be an interesting choice for management of unresectable cystic pancreatic lesion. So this is my conclusion, and I once again like to thank you, the organizing committee, for giving me a chance to give lecture in this topic, and also special thanks to the AEG group to again invite me to give lecture for in topics of endoscopic ultrasound. Thank you very much for your time. Thank you.
Yes, thank you, Professor Brandon Chang, for your informative and excellent talk about pancreatic cystic neoplasm. Yes, thank you. Now this is the time for Q&A.
Actually, there is another lecture of FNA or not for cystic neoplasm. But if time is limited, we can skip that one. But if you still have time, you can listen to that presentation as well. It's totally up to you.
We have a time.
We haven't had the time, so sorry.
Yeah, we love to listen from you.
Okay, so Fola, can you also turn on the next lecturer?
Yes, yes.
I'd like to thank the organizing committee for inviting me to give talk today, and special thanks to course directors, Professor Nuni, Dr. Tan Tan Ai, Professor Mumin Ang. My talk today is to do or not to do FNA in cystic neoplasm. before you perform FNA from cystic neoplasm. For myself, I would follow my rule of 6. In fact, all procedures that I daily perform, I follow this rule. This is to clarify benefits to the patient and also to make sure that you don't do any unnecessary harm to patients. The first rule is indication. The second one is contraindication. When patients have indication for procedure, but they have contraindication, so you cannot do that. And the next one is benefit to the patient. Although you have indications for procedure, but it wouldn't provide any benefit to the patient, so then you shouldn't do. And you have to make sure that patients understand possible adverse events very well in case that some adverse event happen. And even though patients understood all 4 rules well, but if they have better alternatives, so probably sometimes patients might choose alternatives, although we might disagree with them, but it's their right to choose the alternatives. And the last one, make sure that you or your team is good enough for that kind of procedure, and also your place or your institute has good capability or sufficient capability to handle with potential adverse event that might happen from the procedures. So when you see patient with pancreatic cyst, you want to know that what's the nature of the pancreatic cyst. If diagnosis of the pancreatic cyst is main duct IPMN, MCN, or solid papillary neoplasm of the pancreas, you like your patients to see surgeons or interventionists to manage or get rid of this kind of lesions, because we learned from last lecture that those lesions are pre-malignant lesions with potential malignant behavior. However, if diagnosis of cystic pancreatic lesion were cystoadenoma or pseudocyst, then if patients do not have symptoms, we wouldn't do any specific management for that. For branch duct IPMN, you should follow guideline, and the guideline, if you don't have enough time, I would recommend you to look at the guideline written in Fukuoka in 2017, which I already mentioned in previous lecture, and then follow that guideline. And when patients are indicated for EUS or EUS-FNA, you can perform procedure based on suggestion of the guideline. Nevertheless, not all conditions that we can use guideline. Always there are some exceptions. So please remember all the 6 rules that I just discussed. And if there are some things unusual, sometimes guideline cannot be applied to your patients. The other potential for management of the pancreatic cyst, which is branch duct IPMN, is cyst ablation. We don't have enough time to talk about cyst ablation today. In the future, if I have a chance, I am pleased to come and sit down and talk with this again. And the last one is definite malignant pancreatic cyst, but it became unresectable when patients came to see you. So in this kind of case, you might offer them palliative treatment and some novel treatment under clinical trial for management of unresectable cystic pancreatic lesion. So look at diagnostic tests for cystic pancreatic lesion. Available diagnostic tests for cystic pancreatic lesions can be simply divided into 2 groups. The first group is radiological examination. Follow this slide it showed that CT scan has accuracy around 40 to 44%, and MRI accuracy for diagnosis of cystic pancreatic lesion is around 50%. As well, EUS image alone provide accuracy rate from 65 to 96%, so wide range. And once you perform EUS-FNA or FNB, you can provide patients additional 4 diagnostic tests. The first one is cystic fluid analysis, which according to several meta-analysis and systematic review, the pool sensitivity were 63 and specificity was 93% respectively. For cytology from cystic fluid, the pool sensitivity was 64.8%. Both seems insufficient for management of malignant lesions in patient's body. In any kind of potential malignant lesions in body, this value of sensitivity and specificity are not enough. For KRAS and genus mutation, the information seems promising with sensitivity from 84 to 96% and specificity is around 80 to 100%. And the latest test is EUS-guided needle confocal laser endomicroscopy. From recent literature, at least 3 large publications in 2019 and 1 publication in 2020. It provides sensitivity at around 90% plus and specificity at 100% of NCLE. So looking at this diagnostic test, so when you really need and you clarify 6 rules already and you and your patients agree to get EUS-FNA done, so then please prepare for test from EUS-FNA that what are tests that you will offer to the patient for diagnosis of cystic pancreatic lesion. So talk about indications of EUS-FNA from cystic pancreatic lesion. You want to do FNA when the result of FNA has impact to patients and to management. And most of the time, those cystic pancreatic lesions were indeterminate lesions that cannot be diagnosed by cross-sectional radiological images or non-invasive procedure for sure. And you need to know answer and management will be changed because of results of the FNA or FNB procedure. However, you don't want to do FNA or FNB from cystic pancreatic lesion if you know that in the situation that you will do FNA and FNB, the efficacy is too low and there are some contraindications of procedure, and also the adverse event rate is so high. So in these 3 conditions, you don't want to offer FNA to the patients. So we talk a bit about the adverse event classification. This was suggested by Professor Peter Cotton, and we can learn from his classification that for complications that happens to the patient but you or your team can manage during the procedure and do not have sequelae to patients after procedure, we should call incidents rather than adverse events. But any events that might affect post-procedure events, that should be called adverse event. Adverse event can be also classified according to time of presentation and management. Within 14 days, we would call early adverse events. Later than 14 days, we should call delay adverse event. And sometimes adverse event is not directly related to the procedure. So mentioning about relationships of adverse events through the procedure is also important. This will clarify you and your patient's perception later. Level of relationships of procedure and adverse event can be classified into 4 types: definite, probable, possible, and unlikely. And also severity of adverse event can also be classified into mild degree, moderate, severe, or fatal adverse events. So those information should be mentioned clearly in report of procedure or after the procedures. So how about specific adverse events of EUS-FNA or FNB from pancreatic lesions? Perforation can occur in around 0.03%, and it can be found more often in some situations. For example, for beginners, when you pass the scope through esophagus, the risk of a perforation will be increased just a little bit. And in patients with esophageal diverticulum, also increased chance of perforation. And also in patients with esophageal cancer, at this time, we wouldn't recommend dilation of esophageal cancer just to pass the scope just to pass the echo endoscope to do diagnostic tests such as EUS staging of esophageal cancer, because the risk of the perforation is very high in incidence. Infections after FNA or FNB is rare for solid pancreatic lesions. But for the cystic pancreatic lesions, in the past, we traditionally believe that incidence of post-FNA from cystic pancreatic lesion is relatively high. However, in some recent study, it showed that incidence of infection after FNA from cystic pancreatic lesion might not be at that high like we understood in the past. However, in some situations, you should pay special precaution to perform FNA from pancreatic lesions or any organ any organ for FNA or FNB procedure. Those 2 conditions that you should pay special precaution. The first one is mediastinal cyst, which actually most of the time we don't do puncture from mediastinal cyst. We would choose other tests because the incidence of the infection is quite high, and also some case report of post-CPN infection. Pancreatitis after FNA from pancreatic lesion is low, reported rate at 0.44%, as well as bleeding only 0.13%. Biperitonitis after FNA procedure is extremely rare. And how about the seeding? Seeding through the needle after FNA procedure from cystic pancreatic lesion, there were some case reports, but most of case report seeding were reported from malignant solid pancreatic lesions rather than cystic pancreatic lesion. However, 2 large studies show information that no difference of recurrence between FNA versus non-FNA in patients with pancreatic cancer. One of the study was done by Dr. Ngam Reungpong, published in Endoscopy years ago. Authors show risk of gastric or peritoneal recurrence and long-term outcomes following pancreatic cancer resection with preoperative endoscopic guided FNA. It was a retrospective study, and authors correct information from both solid and cystic neoplasm who underwent intent curative surgery, and number of patients was 256. EUS-FNA was performed in 208 patients versus non-EUS-FNA in 48 patients. And authors identified gastric or peritoneal recurrence in 19 cases, and when divided into two groups, 7.7% from FNA and 15.4% in non-FNA group, and they follow patients for 2 years. So then this information demonstrates that FNA doesn't increase risk of seeding through the FNA needle from 2-year follow-up. How about my practice? In my practice, I will do FNA when we have indication and we really want to know, and we are sure that FNA plus additional tests will give us enough information for making diagnosis. For example, in this case, 56 male with idiopathic recurrent pancreatitis off and on for 1 year. We did MRI. The MRI showed a very small cyst in head to uncinate process of the pancreas. We discussed with the patient. We brought the patient to endoscopy room, and we could identify a very small cyst with thin wall, no mural nodule around the head and uncinate of the pancreas. So that was our anticipation. We know that in such small cystic pancreatic lesion, result of cytology will be extremely low, and also volume of fluid that we would aspirate from the cyst wouldn't be enough to making diagnosis from cystic fluid analysis or other tests. So then before procedure, we have discussed with the patient, and we provide the patient EUS-guided confocal laser endomicroscopy. With the help of confocal laser endomicroscopy, we identify a classical findings of papillary projection, which is consistent with intraductal papillary mucinous neoplasm of the pancreas. So this lesion was proven IPM and not pseudocyst. So then we sent the patient for pancreatic resection, and surgical pathology confirmed IPMN. This slide shows one of my cases. She is active female patient with incidental finding of cystic pancreatic lesion. We have followed patients for a year. The cyst has been increasing in diameter. So we and patient, we agree for tissue diagnosis of the cyst. However, from images, cyst has multiple loculations, and each locus has small diameter of locus. So then we have discussed with the patient that if we use standard EUS-FNA procedure plus standard FNA needle, yield might not be at that high. So then we change to use special needle, namely Morris forceps. Morris forceps is trans 19-gauge needle forceps that we can pass forceps through a 19-gauge needle. So then we pass our 19-gauge needle to the lesions, and then we pass Morris forceps through the needle. When you open the forceps and then grab tissue from the forceps. So look at this image. This is fluid that we receive from this cystic pancreatic lesion. Small amounts of zero sanguineous fluid with thin viscosity, suggestive for non-mucinous lesion. But to make sure, we always would like to have pathological diagnosis. So with the aid of Morris forceps, pathological diagnosis in this case is serous cystadenoma. So this is an example of my daily practice that if we anticipate low yield of tissue diagnosis by FNA, we prepare special technique, and one of my special technique is using the forceps through the needle. So from my talk, I like to conclude in this slide. When you want to perform EUS-FNA from cystic pancreatic lesions, you should have enough information that with your procedure it will impact management of the patient, including you might send the patient for surgical resection with the results of FNA, or you might offer the patient for local abrasive therapy if the results show positive or negative result, or you might choose following up of the patient instead of resection of the lesions. And if results impact for such kind of management, that's a true indication for EUS-FNA from cystic pancreatic lesion. And before procedure, you better evaluate cystic pancreatic lesion carefully, and also your EUS-FNA techniques with probable special tools. In general, if cystic pancreatic lesion doesn't have nodules, and wall of cystic pancreatic lesion is very thin, and cystic pancreatic lesion is small in diameter, in those situations, generally, efficacy of EUS-FNA from cystic pancreatic lesion is low. So in that case, you have to make sure that you really need that procedure, and you have to explain to patients and family carefully about expense and probable low yield of the procedure. And if you still truly need to know diagnosis of cystic pancreatic lesion, you might have to prepare some special tools, including Morris forceps biopsy, or in our institute, we mostly use EUS-guided needle-based confocal laser endomicroscopy. That is because of our expertise and our capability. And from recent study in 2019 and 2020, it confirmed high yield of confocal technique as well as our experience. So with this slide, I like to once again thank organizing committee for inviting me to join this lecture, and special thanks to AEG group to give me a chance to have lecture to our Myanmar doctors. And I hope that one day when no more COVID and the sky is open, we will have a chance to give a on-site lecture and educational activities to enhance our friendship. And thank you very much for your time. Thank you.
Hello.
Hello, thank you again, Professor Brandon Chang, for your marvelous talk. Now, this is a Q&A question. Q&A sessions. First question is for Professor Raymond from Hong Kong. The first question is there any tumor seedling in the RFA and its incidence? Professor Raymond, please.
Yes. So now I think we have to kind of think about what lesion are we treating. Now, remember, if you're treating a small neuroendocrine tumor, so you probably don't have to keep going in and out with the needle, right? Then I think once you ablate the NET, the small NET, I think you probably don't worry too much about seeding because you probably kill off some cells, right? But if you are treating a big locally advanced adenocarcinoma, I think, well, sometimes it's not just the target itself is cancerous, right? But sometimes maybe the tumor is already adhered to the wall of the stomach or the intestine. So it's really hard to say what's causing what. But I think I think these are very different situations. So that's why I say, what is the long-term definition of a clinical response? I think we will need to kind of see more data to see. And maybe it's more about quality of life. So, but I think if the patient already have metastatic cancer, then seeding may not be something that's important. So,
thank you.
Yes, I do agree with Raymond.
Next question is also to Professor Raymond. Is the cystic ablation success rate is relative to the size of the cyst?
You know, I think there are studies trying to correlate with that. I think what they are trying to show is that, well, they're looking at cysts of different sizes. Some are as big as 5 or 6 centimeters. But when they try to look at the response rate and they try to have some arbitrary cutoff between the cyst sizes, then they find out cysts greater than 3 or 3.5 centimeters. Then they start to kind of respond not as well. But the real thing is not all the cysts are the same. So I think yes, I think I think intuitively you would say you know, the bigger the cyst, probably the more difficulty in totally getting rid of all the epithelium. But if you can get all the fluid out and adequately infuse the chemotherapeutic agent, or is the lesion has limited number of septations, then maybe it's still okay. But I think these are based on what people have included in the study. But obviously, I think in the beginning, probably don't target something very big. I think maybe start out small and kind of see how things are going before you target something very big, I think.
Can I share to answer this question as well?
Yes.
Hello, can you hear me?
Yes, we can hear you.
Okay. So thanks, Raymond, very much. And based on current literature of EUS-FNA for cystic pancreatic lesion, most of the time they perform cystic pancreatic lesion because they don't want to follow the patients endlessly. So most of the time, cysts that come for IFA, they are small and likely mucinous cysts. But in my center, in those kind of cysts, information is still, still hard to discuss with the patient. So to my experience, I have performed IFA to 3 cystic pancreatic lesions, and those 3 cystic pancreatic lesions, they are huge. Then look at the radiology, it's like a malignant cyst. So they want to do IFA just to relieve symptoms of the patients. So those 3 patients, 2 have malignant IPMN with solid component, and we focus our IFA procedure to ablate solid component inside the IPMN. So that helped the patients a lot, because they reduce volume of the juice that solid component secrete to the pancreatic duct. So then patient symptom relief very well. And the next one we perform on the last 3 centimeter cystic neuroendocrine tumor, and we focus on solid component, and we finally can completely eradicate hypoglycemic symptoms of the patients. So I think that for IFA of cystic pancreatic lesion, the purpose of the procedure can be divided into 2 ones. The first one is small one or medium-sized one, and the next is just symptomatic treatment for malignant cystic pancreatic lesion of the pancreas. That's my idea.
Yes, that's very good point. Actually, that may be, you know, some real life experience that I think is very practical. I think this is good advice.
Thank you.
Thank you. Next question also to Professor Raymond. Is there, do we need lifelong surveillance in the case of this cystic pancreatic neoplasm after the EUS-guided RFA? And how do you do follow-ups in such case after EUS-guided RFA in your clinical practice?
Well, so no, I think these are probably two different situations. So now, if you apply a cystic lesion, I think you have to kind of see when you do it, is the patient already very old, or they're not a surgical candidate, and so I think you only do surveillance probably in the early post-procedure time to look for the response, but then if they are already a very elderly patient, I think eventually you try to space it out, or maybe set a time not to do it anymore. But if they are really young, then I think, unfortunately, like I think it's hard to completely stop it if they're really young. But if you can space it out, I think that's already a blessing. So I think that would be good. What do you think, Padam Chai?
Yes, I totally agree with you, Raymond. Yeah, then that's true. And that's the point that we need to clarify with the patient before we do procedure.
Thank you. Also, another question for your Professor Raymond. If this EUS-guided RFA has any role in the large serious cysts, and how about the measurement size for the sizes of cysts for this EUS-guided RFA?
Yes, so I think that goes back to the idea of targeting something more solid appearing. So I think for SCN, like we're probably not talking about targeting the microcyst, but we're seeing this thing as a solid appearing lesion. So I think the goal here is maybe to reduce some mass effect, because I think most of the time, if SCN is going to become malignant, this is going to be big. This is going to be locally aggressive. So I think we're just trying to reduce the mass effect. So
yeah. Can I share my opinion about this question? Okay, sure.
Yes.
So at this time, look like that in most literature, they recommend IFA. Perhaps if I'm wrong, Raymond, you can correct me. Most literature, they recommend IFA in potentially malignant cystic pancreatic lesions.
Yes.
Not already malignant cystic pancreatic lesion.
Of course.
And also not benign cystic pancreatic lesion as well.
Yes.
So all the literatures at this time, it's just indeterminate one, which is not a malignant one yet. And if you look at the principle of the cyst aberration, not only RFA, because RFA is one of the cyst aberration methods, right? We can use RFA, we can use alcohol, we can use chemotherapy, right? Yeah. So the purpose of those cyst aberration is just to do aberration to reduce following up time. Yes, that's it. But they wouldn't do cyst aberration in patients with definite malignant cysts. If they turn out already malignant and is still potentially resectable, you should send the patient for surgery at this time.
Yes.
Yeah, that I want to share. Yeah.
Yes, that's actually very important, because if there's a potentially resectable lesion, and if you think they are pretty fit and healthy, then I think surgeons should see them, definitely.
Yes.
Thank you. Next question also to Professor Raymond. This technical question. What's the principle of EUS-guided RFA in this cystic neoplasm, whether from lateral to center or from distal to proximal?
No, I have to say that I have limited experience with using it in cystic neoplasm, actually. But I guess we're targeting the linings of the cyst. But I guess, my understanding is if we can empty some of the fluid, then the contact may be better. But maybe like Madam Chai, maybe can you maybe share with us what you think about the what's the way to go in this one?
Yeah, actually, for technical point to do RFA for cystic pancreatic lesion, we do we'd like to abrade cystic wall. So when we like to abrade cystic wall, the way that we can do, we have to try to make the cyst smaller. And when you use the IFA to abrade wall, and it's very difficult to answer the long-term sequelae from aberration of cystic pancreatic lesion, like Raymond showed in his slide that the largest study is from Bartet, from Marseille.
which following up years is just only about 1 year for post-IFA. Longer term follow-up been reported with cysts being abraded by alcohol and chemotherapy, which both methods, they're liquid and they can go and they can touch and they can abrade all area of the cystic wall. But for IFA, it's a hard and straight needle. So we're not sure at this time. I have same opinion with Raymond.
Thank you. Next question goes to Professor Brandon Chai. What is the role of serum CEA or CA199 in the case of this pancreatic cystic neoplasm?
Actually, like in my slide, those analysis we call cystic fluid analysis. For cystic fluid analysis that we routinely perform in Southeast Asian country, we send the fluid for cytology, we send the fluid for CEA and amylase. But as I discussed, the sensitivity of cytology is very low because it's been diluted with the volume of the fluid. So then most of the time, if you have limited amount of the fluid that you obtain from the cyst, the first test that you want to send is CEA. And the second one probably the cytology or amylase. But for the CA99, information of CA99 for diagnosis types of the cystic pancreatic lesion is very limited. And I think that difficult to answer sensitivity and specificity of CA99 in the fluid. So to answer the question, we better send for CEA rather than CA99.
So for present time, this they asked about serum. I think is this more serum CEA.
Yeah, they're asking serum, in the blood.
Or they're not answering about in the cystic fluid, right? If it's in the blood, CA99, amylase and lipase is more important than CEA. But please be noted that CA99 can be also elevated in benign condition, and those conditions include pancreatic duct obstruction, bile duct obstruction, and inflammatory disease of the pancreas as well. It can be elevated in both benign and malignant condition. Yeah, so have to be careful when you use CA99 as a marker for diagnosis of cystic pancreatic lesion.
Thank you. The last question also for Professor Brandon Chai from Professor Kinsan A. The question number 1 is, how can we predict potentially malignant cystic lesions according to EUS finding?
Actually, in general, sensitivity is not good, but specificity is quite good. If you already know that clinically the patient doesn't have pseudocyst, so the next thing that you will look at is solid component inside the cyst. If inside the cyst it has solid component, it's not a good sign. You might have to be careful that it might be the malignant potential cyst like a mucinous cyst or IPMN. And the diagnosis of IPMN, sometimes the information from the image is pretty helpful. So if you found some signs from radiological imaging suggesting for malignancy, mostly is pretty more specific, but sensitivity is low. So if you don't see those findings, that cyst is still have a chance to be malignant cyst in the future, not at this time. But for the recent information from recent guidelines, say that even though in some small cysts, sometimes it has some high-grade atypia on that. So they recommend that in any kind of cyst that seems to be a little bit bigger, maybe it would be good if you can have cytology from the cystic wall. But as I discussed, sensitivity of the cytology is very low. So even though you try to do that, but sensitivity is very low. So at this time, that's why confocal laser endomicroscopy has a increasing role, because from 3 papers in 2019, it has been proven that confocal laser endomicroscopy has a better sensitivity and specificity than other tests for making diagnosis of the cystic pancreatic lesion. And this year in 2020, it findings from control call, it can divide low grade versus high grade or cancer from wall of the IPMN. So yeah, I think that I have answered the question. Thank you.
Next question is, how do you make decision on cystic pancreatic neoplasm with clear indication for surgery?
Or clear indication for surgery. Yes. Whenever you think that those kind of cyst is cancer, it's clear indication for surgery if it's still resectable. But if it's unresectable, you might offer them RFA. No information of that, but you might offer them. But once you prove that the patient has cancer already at this time and is still resectable, no indication for local ablative therapy, you need to send the patient for surgery. But because surgery is very high risk for pancreatic surgery, so that's why you need, in some case, you need to prove it before in some equivocal case. So that's an indication for the FNA.
Thank you. The last one is there are many potential adverse events associated with EUS-FNA or this pancreatic cystic lesions, and are there any measures that can be taken to prevent such complications?
The most common complication of FNA from cystic pancreatic lesion is infection. And the way that you can prevent the infection is giving the patient antibiotics, and don't keep the needle inside the cyst too long. Because longer the cyst inside the cyst, higher chance of the infection. So once you go in, you get what you want, you get cytology, you get enough fluid, you take the needle out. Because in the first few study of the control cohort, we have identified more infection and more higher incidence of pancreatitis if we leave the control cohort needle inside the cyst too long.
Thank you. Yeah, these are all the questions.
So now, hi, this is Jason. So now it comes to the post-test now. So I would like to share again the test. Okay. So in case there is some attendees join lately, so we are going to do the post-test after 3 wonderful lectures. So the test will have 5 questions, and please take your time to answer all the questions. All attendees are welcome to answer. So you will have a screen pop up now. Okay, now you will have a post-test showing on your screen. Altogether, there are 5 questions. So we will end the test after 5 minutes. Then we will show the answer, and we will invite our faculties, Professor Kon Kam and Dr. Raymond Tang, to explain the answers. Please take your time. 2 minutes left. Last 15 seconds to answer. Okay, thank you all for answering the questions. Then we'll go for the answer now. So for the first questions, the answer is A. May I invite Professor Pramchai to explain the answer?
Okay. Thank you very much, and I'm very glad to see that majority of you answered the correct question, because enhancing mural nodule is definite size for potential malignant cystic pancreatitis that you need to send the patient for surgery. And for 2 centimeters with a stable diameter for 8 years, you can observe and follow them maybe sometime, not every year, sometime couple years or something. And honeycomb appearance is a typical feature for thalassic adenoma, as well as if cytology show cuboidal cell with a positive stain for glycogen. So yeah, congratulations. So we go to the second question. So the second question, as I discussed, everyone, yeah, go back. So the question is that, what is the highest diagnostic yield as a diagnostic test? For specificity, you know that cytopathology is very good, but because it has very low sensitivity, so at this time the latest information from 3 large publications from various centers has shown that needle control provide the best diagnostic value for both sensitivity and specificity for diagnosis of cystic pancreatitis. However, because the price is very expensive and it's technical demanding, and it needs learning curve to do EUS confocal laser endomicroscopy, so it's not widely used in the world at this time. But in the future, if we go more and more, I think that we will do FNA less and less. But whenever you want to do FNA, you need the highest yield test. So confocal laser endomicroscopy seems to be the best one at this time. So that's my answer. Yes, thank you. So we go to the third question for Raymond.
I invite Dr. Raymond Tang to explain the questions in the following.
Okay. So this is a question. Okay, so EUS-guided cyst ablation is an option for management of pancreatic cystic mucinous lesions in pancreas. So, well, which one is considered a contraindication? So now we emphasize that we should make sure there's no obvious evidence of cancer associated with the lesion. So answer B, will be the thing that we should remember. So on EUS and CT, we should rule out evidence of cancer before we do the treatment. So now, a mucinous cyst without direct communication, main PD is a good thing. And the mucinous cystic lesion that are unilocular or oligolocular is also a good feature for success of the ablation. And also, mucinous cyst with thin septum is also good for the procedure, okay? Okay, so now this question is about which of the following agents have been reported in clinical trials for EUS-guided cyst ablation. Now, so in our lecture, we went over the types of agents people have used before. So now, definitely in the early days, they're just talking about alcohol, ethanol lavage. Then over time, people start to add chemotherapeutic agent to it. So B is correct. And then C, alcohol-free saline lavage, followed by a mixture of combination chemotherapy agents. So this is also true. So and D, Morocco is also have been reported. So the correct answer would be all of the above, because all of these have been described. So, okay. So the potential utility of EUS-guided RFA has been reported in which of the following? So now we have 4 choices. So again, we have seen reports on the neuroendocrine tumor and also unresectable pancreatic cancer and certain types of cystic neoplasms and liver tumors. So again, the correct answer should be all of the above. So this is something we went over too. So hope you have a better understanding of the topic.
Okay, that's the end of the post-test. Thank you all attendees to participate in the test.
Thank you. Excellent lecture, Raymond and Professor Brandon Chai. Thank you.
Thank you very much. Thanks.
Okay.
I'm over to the closing remarks. Thanks.
Thank you, everybody. And now this is the closing sessions. And before end of our closing of the webinar sessions, I'd like to say some few words. This is a very educated and exciting sessions with many learning points and a lot of discussions, and lively discussions. I'm sure that all the participants has learned a lot about the pancreatic cystic neoplasm, EUS-FNA, EUS-guided RFA technique from all the two eminent speakers. And I also like to express our special thanks to the Professor Lauren Ho from Singapore. He's the president of AEG. Also the Miss Flora from Hong Kong, and also Olympic team, both from Singapore and Myanmar. Also the Professor Tantan is team from the University of Medicine 2, Tenganjong Samjia General Hospital, and all the participants. And hope you see in the near future, in the live conference in the very near futures. And the last but not the least, our special thanks go to the two famous speakers from Professor Brandon Chai from Bangkok, Thailand, and Professor Raymond Tan from Hong Kong. And I wish all of you the healthy and safe, and all of you free from COVID-19 from now and forever. Thank you very much.
Yes.
Thank you.
Thank you, everybody, taking the time. Thank you.
Thank you. Thank you. Thanks. Bye.